Hello everyone. The Moroccan ENT Society welcomes you to this webinar dedicated to the endoscopic endonasal surgery of the anterior stage of the school base. We are very happy to welcome our guest, Professor Ricardo Caro, that has nicely accepted our invitation. I will let Professor Mohamed Zala present Professor Caro's resume and achievements. I would also like to thank everyone who is attending this webinar. You can ask your question in French and we will try to answer most of them during the session. If not, the answers will be addressed by email since Professor Caro has only 1 hour and a half with us. The current board of the Moroccan ENT Society, like its predecessors, would like to offer a continuous medical training to its fellow Moroccan doctors, opened to all languages and scientific cultures. During this pandemic of COVID-19, webinars have been an example of partnerships that we want to continue to develop with scientific societies across the world. The endoscopic endonasal surgery has started in our country in the 1990s. It has started, like for other countries, with the functional pathology of the nasal and sinus cavities. Then, about 10 years ago, Moroccan ENT doctors began to use endoscopic endonasal surgery for pituitary adenomas using sphenoidal route. And in recent years, it has been used for the pathology of the anterior stage of the base of the skull, thanks to new equipments for neuronavigation, micromotor, and improvements in imagery. It is a good start, but there is still a lot to do, like, for example, develop the collaboration with neurosurgeons that is only slightly perceptible for now. Again, thank you everyone. I will now give the floor to my friend, Professor Faisal Al-Fihri, to present the objectives of this webinar.
Thank you so much for your kind invitation, Professor Leila Istakali. It's a great honor for me to moderate this, this event. You are the guardian of the temple and the protector of the house. You have to take care of my generation legacy. The future of the Moroccan Society of ENT and HNS that you preside over is in good hands. Also, that one of the otorhinolaryngology department, of which you are the head, you are involved in many scientific activities and doing a good job for extending our relations abroad, teaching and training. I mentioned also that you have been involved recently during the pandemic in the task force against the virus. Where do you get this strength and energy? You represent for me the image of the Moroccan lady, proud of her culture and her past, but resolutely turned towards modernity and future. So, again, welcome to all the attendees and friends, and hello to my team at the clinic. Today, we have an exceptional guest out of the ordinary through his professional background and his tremendous work in cross-border surgery. In cross-border surgery of the skull base, I named Professor Ricardo Carao from Columbus, Ohio, USA. Buenos días y bienvenido, profesor. Gracias por estar aquí con nosotros. Let me just introduce the team. It won't be too long, just about 10, 12 minutes. That will be just an appetizer. If you don't mind, let me just expose some thoughts. The future is near, but it seems to have no limits. In medicine and in ENT in particular, there has been unbelievable changes in just 3 generations. And today, we are gathering with 3 generations of ENT. What can I say to the youngest generation? There is always a West to discover and to conquer. I mean, it's not just a direction, it's a symbol, it's a metaphor. Just make your dream reality. Just break the glass ceiling above your heads and go to find out newfound lands. And endoscopic surgery is one of the most exciting and promising territory to explore. But be armed, work hard, learn hard, and learn more of your mistakes, and go step by step beneath the cover of your seniors. New technology, new techniques is not always accepted with open arms. It takes time to prove it. Classic surgery paradigm was the more you get exposed and the better you are, and the better you feel. But there are detractors, the bad guys. At the very beginning of endoscopic surgery of the year, it was often laughs and dubious scoffs, like, what the heck are you doing here? Why look through a hole, through a keyhole? Does it make sense? The most recurrent criticism was, you've got 2 hands, and why the heck use only one? That's so easy to handle. It's like building a boat in a bottle, and so on and so on. Very controversial subject. But this debate is sterile between the refractory in principle, who you never convince, and enthusiast without limits, who you do need to curb. For me, the debates belong to the past. The most important is the patient and how to cure his pathology. The major objection of the one-armed surgeon, the answer to this question, the answer is simple. We are talking here about skull base and about a team of surgeons, and there are at least 2 surgeons, so there are four hands. Nothing is new on earth, I would say. In ancient times, Egyptians knew exactly how to go inside the skull through the nose and to extract and remove out the brain during the mummification process. They used long hooks. There are many advantages using endoscopes. You can go closer, you can go direct. You can open and widen your view. And small is beautiful when you have to perform a minimally invasive surgery. Perhaps it's faster and better. There are better recovery, less destructive, better outcomes, better quality of life, more acceptable by patients, better for viewing by a team, cheaper perhaps, and certainly more fun. During the last decade, the rapid evolution of technology, and particularly the quality of endoscopes, light sources, high-definition video cameras and displays, medical imaging, navigation aids, brain monitoring, anesthesia, ICU, better knowledge of surgical anatomy and landmarks made it possible to push the limits and to set up the concept of minimally invasive surgery. This minimally invasive surgery is not a minimally cure of the disease or of the pathology. It does exactly the same as the traditional. That is to say, using new corridors, even tight ones, less aggressive and less destructive approaches with best recovery and minimal sequels, better outcomes, and improved quality of life for patients. This is an in-between surgery. And what is the challenge? The skull base lies at the anatomic boundary between the field of neurosurgery and otorhinolaryngology. This surgery needs new skills and expertise. Actually, one could say, how to go inside the box? How is it possible to go inside? The answer is that there are windows and pathways to use. These highways, I would say, routes. There are corridors, and we can classify the approaches according to two planes of space: sagittal in the midline, which interests us today, and coronal or horizontal and lateral. Our topic today concerns the sagittal plane and the transnasal approaches. And here are the main corridors. Depending on the area you want to reach, it's a problem just of anatomy and conceptualistic geometry. Professor Carr will talk about that, I presume. And when you compare the two techniques at the left, the traditional, and the right, the minimal, as we say in French, il n'y a pas photo. The evidence is clear, and there is no contest. That is the answer for this question by Dr. Justin Kolb, assistant professor at Columbia University, Presbyterian Hospital, New York. He says, must go on hands-on courses, temporal bone labs, graduated practice, patients, a lot of patients, and YouTube. Before I end this intro, may I focus on one extremely important and crucial point, the training. Learning the prerequisites, having deep knowledge of anatomy of the region, on cadaveric dissection, immersion beneath a team, and step-by-step training to acquire progressively, level by level, sufficient experience. The learning curve is long, and the main goal is high knowledge of landmarks, and they are mandatory for not to be lost or confused. And here are the milestones for progressive training. And they are spread from level 1 for the easiest procedures to the highest and to the most difficult level 5. I don't want to explain that, to detail that. That'll be, I think, that'll be done further. Never jeopardize unnecessary. You have always to be aware of possible issues and to transform. You must know how to transform the surgery. Be prepared always. And before leaving the floor, just give me the opportunity to point out 3 things. The future is promising, but all of us can expect to change the way we think and act daily. We have to open our minds and the way we live medicine, not with blinded eyes and with no interest for our neighbors. The best example for success is the collaborative and transversal experience inside multidisciplinary teams in endoscopic surgery of the skull base. I like people who share, collaborate, and are not scared by going to the other side of the border. Just be curious. Second, you have to build bridges all the time and to unify. Actually, and furthermore, the pandemic has created a situation revealing certain shortcomings and weaknesses. We have to consider that humans are not alone in this earth. You have to remember and teach that there is much more. Animal, plant, marine, mineral world, and humans continually interact, and diseases have no barrier. There is one world and one health. And third, at last, I say, like Steve Jobs, and I like very much, one more thing. Yes, Mr. Dylan, the times, they are changing. This is my bibliography, and at last, I would like to thank a lot Dr. Yahya Salhi and Dr. Salah Dahlan for their great job within our Moroccan ENT community for nourishing greatly our digital library and our social media. Also, I can't end without expressing my admiration to Professor Hassan Shedli, who is pioneering endoscopic ear surgery in Morocco and abroad, with great success and brilliance. And now let me call Professor Zalar to present our distinguished guest. Thank you.
Hello?
So I call Professor Zalar.
Vous m'entendez? Can you hear me? Can you hear me, please?
Hello, Professor Zalar.
Hello, can you hear me?
Yes. Go on, please.
Can you hear me?
I hear you.
You see my screen? You see my screen? You see my screen?
No, no, no.
You see my screen now?
Oui, professeur Zalal,
Yes.
on voit votre écran. Ouvrez tout simplement votre PowerPoint et vous le lancez. Voilà.
Oh, my gosh,
Oui, on voit votre PowerPoint. Oui, oui, professeur Zalal, on voit votre présentation. Vous pouvez commencer.
So I can begin, please. Okay. Hello, everyone. I'm Professor from Military Teaching Hospital in Rabat, Morocco. First of all, Rabat, please, you are welcome once again to another interactive. The current president of the society is Professor Layla Sali, head of the ENT department in University for this webinar. Also very happy to be joined as a moderator by Professor Rabat. It's my great pleasure to co-moderate with you today, which is received, as has just been said, such an eminent figure in ENT surgery, Ohio State University, USA. Yes, Professor Caro is in fact a non-common surgeon who hear me? this problem.
Professeur Ferry, pouvez-vous reprendre la parole, s'il vous plaît? Réactivez votre micro. Voilà.
We're short of time, so I apologize, but I would like to, perhaps I have a better upload. I would like to give just some landmarks. Professor Ricardo joined the Department of Otolaryngology and Head and Neck Department of the Ohio University as tenured professor in otolaryngology and head and neck in April 2011. He's the acting chair of the department, director of the comprehensive skull-based surgery program, is co-director of the research and education laboratory, Alt Vision Anatomy Laboratory towards visual spatial innovation in otolaryngology and neurosurgery, and medical director of the OSUMC Global Health. The comprehensive skull-based surgery program is part of the Head and Neck Oncology Division at the James Cancer Hospital and the Solovs Research Institute of the Ohio State University Medical Center, with ties to the Division of Rhinology and Neurootology. Dr. Carroll's clinical interests are diverse and include swallowing disorders, traditional and endoscopic skull-based surgery, head and neck oncology, disorders of the salivary glands, and colonoscopy disorders, and the paranasal sinuses and endoscopic sinus surgery and laryngotracheal stenosis. Dr. Carroll has developed a remarkable CV, having authored over 600 publications, 450 plus peer reviews. He has co-authored, co-edited the book Operative Otolaryngology, Comprehensive Management of Swallowing Disorders, Clinical Manual of Swallowing Disorders, Clinical Management of Swallowing Disorders, Atlas of Cirrhotica Endoscopica y Pathé de Cráneo, Asociación Colombiana de ORL, and then maxillofacial aesthetica fascia, and dissection laboratory manual for endoscopic skull-based surgery. Dr. Carroll is a recognized world expert in skull-based surgery and a pioneer in endoscopic skull-based surgery. He has been instrumental in developing techniques, defining the indication, and solving many of the challenges presented by patients with pathologies in this complex area, including swallowing disorders resulting from both the conditions and their various treatments. And what can I say? I gently see him at the time. I tell him exactly what we are very impressive. I had finished, Ricardo, and I give it the floor.
Thank you so much for your kind introduction, and thank you even more for the invitation to be with you today. Can you see the slides? If you can give me a little bit of feedback, I just want to make sure that things are working well. Okay. Perhaps then the moderator can send me a message if there is a problem. Otherwise, the task today is we're going to talk about anterior skull-base surgery resection from an endoscopic standpoint. I want to introduce the members of my team. Dr. Prevedelo and Dr. Hardesty are two of the neurosurgeons that I work with. Dr. Otto is part of our rhinology team, and Dr. Kyle Van Koeveren is joining us from the University of Michigan at the end of the month. He will be the third ENT in the team. So I want you to just bear with me. I'm going to give you a little bit of the history of anterior skull-base approaches. Basically, from the 1960s to the 1980s, the resection of the skull base was done mostly transcranial. So what that will mean is that the brain had to be retracted to get to the skull base. Many surgeons recognized that that had some involved morbidity. So from the 1980s to the 1990s, for the most part, we were using a subcranial approach. And the idea of this is that you remove the bones in the front, and that way you have to manipulate the brain less, and that would lead to less morbidity. From my standpoint, one of the greatest advantages of the endoscopic approach is that we come from a more ventral direction. So there's even less manipulation of the brain and therefore less morbidity from that standpoint. By using the endoscope, we can also bring illumination to areas that it would be very difficult to bring with an external or a microscopic approach. So I'm going to go through these schematics and explain my point. Basically, the way that we see is by bringing light into the surgical field. So the human eye cannot see without light of the visible spectrum. So when we do an external approach, we have this cone effect where we move a lot of tissues around so we can bring the light to the bottom of our surgical field. So it works into something like that for the anterior skull base. With the microscope, we have great magnification, but the problem with the microscope is that you have a cone of light that is inverted. So basically, anything in between the microscope and the field that you are trying to target will stop the light, and your field gets smaller and smaller. You can magnify it, but the field is very small. So it will be something like that, like what we used to use for pituitary. So here's the problem with these two approaches. You can see this fort, and if we want to go look through the window of the watchtower, we can magnify that window. However, we're always bound by the framework of the window. We can magnify it all we want, but we really cannot see through the sides. The endoscope, though combines the two characteristics, and it gives us kind of an inverted cone as opposed to what we had before. So now we can bring illumination to the field through a minimal access approach. So we can put that endoscope through the window and we can see through the sides. However, that doesn't come without a price. It comes with a price of having to learn the anatomy from the endoscopic standpoint. The perspective is different, the anatomy doesn't change, but you get disoriented. You get disoriented again because it's a new perspective, and you get somewhat disoriented because the endoscope, especially the endoscope with angle lenses, have some distortion, and you can have extreme magnification. So the endoscopic, because of the camera, especially with the angle scopes, the endoscopes is the only visualization tool where the surgeon can lose where the feet and the head of the patients are. And I explained, with a 30-degree scope, if the camera is twisted, instead of looking up like you think you're looking, you could be looking to the side. So that causes disorientation, and it may lead to serious complications. So when we tackle the endoscopic approach for the anterior skull base, especially for malignancies, The surgical outcomes are measured in the same way. The goals are measured in the same way. We have oncologic goals, functional goals, and cosmetic goals. For the most part, these two doesn't change. The cosmetic goals are somewhat different because we do not have any incisions, we don't have any mobilizations of the bones that will cause a cosmetic effect. The way we do it, as you all know by this time, is a bimanual technique. So we have two surgeons working at the same time, using the two nostrils, using 4 hands or 3 hands on multiple occasions. This is dependent very much in instruments. So you can be a great surgeon, have great skills, but if your instruments are inadequate, you won't be able to do a great job. And the list of instruments that we use nowadays becomes larger and larger. So the more minimal invasive you are, the more dependent you are on adequate instrumentation. And of course, when we're talking about this, we're talking about a procedure that requires experience. It requires experience from the oncologic standpoint, and it requires experience from the rhinologic standpoint. So it's the combination of the two skill set that will give us the best outcome. So basically, we're going to be tackling this area over here. This is a view like if we're lying on the floor of the nose. If I would be lying down on the floor of the nose and look up, this is what I would see if I'm doing an anterior skull-base resection. We have basically the two orbits on the sides. We have the sphenoid sinus at the bottom, and we have the frontal sinus at the top. And you can see that we have skeletonized the ethmoidal arteries. The anterior ethmoidal artery comes out through the orbit, and it has this diagonal orientation. It always goes from posterior to anterior. It can go up or down, depends on the pneumatization of the sinuses, but this orientation is always true. The posterior ethmoidal arteries, which happen to be just in front of the rostrum of the sphenoid, have a more horizontal orientation. Because of the perspective with the endoscope, when we really look with a 0 degrees, and I'll show you a couple of views of this, they look like they are going in a different direction of the anterior ethmoidals. So we have to remember also that in many of us, we have a middle ethmoidal artery. We always talk about the anterior and posterior, but in many of us, the middle ethmoidal artery is going to be significant. So basically, the ethmoidal arteries divides the anterior skull base, at least from the endoscopic standpoint, which is in this paramedian region, in 3 areas: anterior to the anterior ethmoidals, in between the two arteries, and posterior. And there are different pathologies that happen in each area. For the most part, this area over here, the middle, is the one mostly affected by tumors, is the one mostly affected by iatrogenic or accidental trauma. The other ones have other characteristics, as I will talk about later on. So it's important to recognize the limits of the skull-base resection when we're doing it endoscopic. So from the lateral standpoint, we can get to more or less a meridian of the orbit. What I mean is, if you have the roof of the orbit and you divide it in 2, you can get more or less to the middle of the roof of the orbit. If something that extends beyond that, it will be very difficult to tackle. And of course, you can try to develop the tumor in the center and bring everything in, but sometimes that doesn't work that well. We can remove the lamina papyrica and kind of displace the soft tissues of the orbit and get a little bit more, but it ends up that is not going to be much more than what I just explained. From the height standpoint, it is really not that important, although I will mention some exceptions later on, especially again for oncologic standpoint. Now, as the orbit goes back, let me go back for a second, and we get into the apex of the orbit, and we get closer and closer to the optic nerve. That really becomes a little bit more of an issue. You can move less and less lateral because you really cannot mobilize the optic nerve laterally to get a little bit more of a resection. So that is important to remember. Both the optic nerve and the ophthalmic artery are not mobile for practical purposes and are going to limit how lateral you can get, and it's going to limit what type of tumor you're going to remove from an endoscopic standpoint. Other things to have into account is whether or not the tumor is invading the brain. Here, this is just a benign meningioma, but you can see that the flare effect on the brain, that means that the pia has been invaded, and this is going to be a much more difficult resection. You also have to take into account where the vessels are going to be. The vessels usually are at the periphery of the tumor, but sometimes are inside the tumor. So those are things that we, again, have to consider before considering the endoscopic approach. So all these have been done through an endoscopic approach. So let's use an olfactory neuroblastoma as our model on how we're going to do an anterior craniofacial resection. So if you are a so-called beginner in this, and by beginner, I mean an experienced surgeon that is beginning to get his hands involved or her hands involved in resection of the anterior skull base. So here we have an excision neuroblastoma that may seem ideal as your first case. You can see that the scission is only unilateral, it's only in one side of the nose, it's not invading the orbit in neither the CT nor the MRI, and it's not invading the brain in neither one of them. So when we are talking about skull base and anterior skull base, something that I emphasize that many times our surgical margins are really philosophical, are not really oncological. If we take a piece of the tongue, for example, you're going to strive to have oncologic margins of 1 centimeter or so. Unfortunately, in the skull base, many times we cannot do that because we have critical structures that we don't want to hurt. And that's what I mean that the margins are philosophical. So the margins, the extent of the resection is really dictated by what do you want to preserve, what is critical to you and your patient, and therefore you're going to stop there. So what happens in the skull base surgery is that many times we're very close, or we have minimal margins, or we have no margins in some cases. So here we have an examination of the left nostril. I'm showing you the same tumor that I showed you in the imaging before. You can see some fibrin because the tumor was biopsy before. So the first step that we are doing here is we're debulking the tumor because we want to see really where the tumor is originating. And this tumor, read the book, basically is originating from the superior septum, the vault of the nasal cavity, and the middle turbinate. But sometimes you cannot see really where the base of the tumor is until you debulk it. Some tumors are going to be they are arising from the septum. Some tumors are going to be arising from the roof. Some tumors are going to be arising from the middle turbinate, or all of it, like this one. And you're not going to be able to figure that out until you debulk the tumor sufficiently. And in this case, this is a relatively small tumor, but tumors that invade, that occupy the entire space of the nose, is really difficult to ascertain where the tumor is arising from until, again, you debulk it. So the next step, as you can see here, is we have resected the middle turbinate. That gives me a lot of space, and it helps me to explore the lateral aspect of the cavity, which is really the lamina papyricia, the orbit, that it doesn't seem to be involved with this tumor. We're going to do a very wide nasoantral window and a very wide sphenoidotomy. Aside from getting control of those sinuses, that serves as a coordinate, as two coordinates to know where the roof of the nasal cavity is, the skull base, and of course the nasoantral window is going to give me the floor and the medial aspect of the orbital walls. Control of the anterior ethmoidal arteries. If you look at the inset picture here, this is what I was talking about before. Here you have the anterior ethmoidal arteries going from posterior to anterior, and the posterior ethmoidal arteries seem to go from posterior from anterior to posterior, but that's really a kind of a visual effect. It's not true. And here I continue to show this slide where I'm clipping the anterior ethmoidal artery. The truth is that I don't do that anymore, and the reason is that the clips come off in the middle of the surgery. Sometimes you can lacerate the artery. So nowadays we basically bipolar the artery until it's really well cauterized, and then we divide it. Septal incisions, you can make them as you deem appropriate for the different tumors. In this particular case, you have them here. And at this point, and basically looking looking up, and basically this is the diagram of what I showed you at the beginning. You will have the frontal sinus, you will have the sphenoid sinus, and you have the orbits on the side, and you may or may not have to remove the lamina papyricia. It just depends on the case. And of course, the ethmoidal artery is in control. We examine the other side because these tumors seem to be unilateral, and one of the advantages of the endoscopic skull base is that sometimes we can do a unilateral resection. In this particular case, it seems to be possible. Well, of course, we're going to confirm that with frozen section analysis. So this is a different case, just to show you the same schematic that I showed you before. Here you have the frontal sinus, you have the orbits in the two sides, and the sphenoid sinus in the back, and we have basically surrounded the lamina, the cruciform plate, and you can see that we have already begun to remove the skull base. You have dura exposed, maybe some defects in the dura. So the way that I resect these tumors, although you could do it in block, we did it several times, and once in a while we still do it. But for the most part, we think that it's safer to do it in what I call a sequential multi-layer resection. What I mean by this is that we have removed the tumor, we remove the mucosa and the bone that needs to remove. In the meantime, you can send frozen sections for analysis, make sure that your margins in the nasal cavity are okay. And basically then, at the end, you're gonna remove the dura and the olfactory bulbs in one block. So this is a cadaveric dissection, again, illustrating the same concept. We have removed the nasal cavity tumor, we have removed the affected mucosa, we have exposed the bone of that anterior skull base, removed the bone, exposing the dura, and then we're gonna start resecting the dura. You can see that we start by incising laterally first. And the reason for that is that the frontal orbital vessels and other frontal vessels are going to be in the middle. So to avoid any damage of those vessels and to have better control, we start on the sides. Once we have done the side cuts, then we do these incisions under full visualization to join the two. And as you go from anterior to posterior, which is the direction that we usually follow, you will identify the faults, which is dividing the two hemispheres of the brain, and you're going to remove the faults as high as you can see. And at that point, you're going to have the arteries in full view. And by arteries, I mean the frontal orbitals. So this is the same case I was showing before. I'm going to stop here for a second, because at this point, we have removed the bone, we have the dura exposed, and when we look in here, we really don't see any tumor over the dura. And it may be tempting to stop here. The MRI, remember, that didn't show any gross tumor, so you may be tempted to stop. Here's what you have to think about the biology of the tumor. If this would be an adenocarcinoma, it would be very appropriate to stop here. If you would be operating a melanoma, it would be appropriate to stop here and not destroy barriers. However, esthesia has a tendency to have perineural spread. We know that it really can follow the nerves, and that's why we remove the bulbs and the olfactory tracts. So we decide to open the dura, and here you have it, voila. You have tumor on the other side that had escaped the MRI. It's not very bulky tumor, and you can see why we didn't see it in the MRI, but you would have left it in there. Some people would contend that maybe you can treat that with radiation, but the truth is that we don't know. These tumors have to be followed at 15, 20 years. So the series that have used radiation do not have that type of follow-up, and those that have some follow-up have found that the tumors do come back in long term. So from my standpoint, thinking as an oncologic surgeon, you should remove the dura for anesthesia. So as I mentioned before, one of the great advantages of the endoscopic approach is that you can resect tumors unilaterally. Now, for aesthesios, I only do that if the tumor is unilateral, if it is not intracranial, and if it is not invading the septum. And the reason for this too is that there are connections from one side to the other at the level of the septum, and at the level of the bulbs. So if one side is positive, it is possible that the tumor is extending to the other side and you may not identify it. So if it is not doing this, then I do a unilateral resection with the idea of preserving all function. Here you have the tumor that I showed you before, and this is basically the defect. We have a defect which is really the same as you would have with an open resection. You have from orbit to orbit, and basically from the planum sphenoidale to the frontal sinus. So now it's time to talk a little bit about reconstruction. So reconstruction, when we're tackling meningiomas, that we're doing the same approach, but the tumor is really at the top and it's a benign tumor. For the most part, we use a pedicle flap, the nasoseptal flap, because the septum is not involved. When we're talking about with malignant tumors, many times that is going to be removed. So you won't have the nasoseptal flap. There are other alternatives, as I'm going to mention in just a second. What I want you to think about is that you have to have the ability of reconstructing this defect without having to think about what do you have to preserve to reconstruct. And what I mean is, for those of you that only use free grafts, we know that we're always thinking about how big of a defect we're going to get, because the bigger the defect, the more difficult it's going to be to reconstruct, and we need some type of ledge to really hold our grafts. Now, if you have the ability to do flaps, that is not a consideration anymore. And this is important when we're dealing with oncologic cases, because again, the main idea is to cure the patient of the tumor. So if you do have a nasoseptal flap available, this is a great alternative. As you see here, postoperative CSF leaks is less than 5% when we can use it. Other alternatives, we have the Haddad flap number 2, which is really this lateral nasal wall flap that is based in the anterior side, and you can use it instead of the nasoseptal flap. We also have the regional reconstructive flap, the old pericranial flap, that we can place it through a window in the nasion and reconstruct the anterior skull base, as I'm showing here in this video. So you can see that only half of the pericranium, this is only half of the frontal pericranium. If I go back to the previous picture, we divide this in two and have two flaps. We only half of that is sufficient to reconstruct the anterior skull base from orbit to orbit. And I have to mention that some of my friends in Italy and Miami, the Brescia Baresi group, Castelnuovo and Piero Nicolai, they do not use a flap for the anterior skull base resection. I use a flap, but I use their technique also. So basically, when I reconstruct the anterior skull base, I use fascia lata and then I cover it with pericranium. The advantage of that is that it mucosolizes very quickly. To my view, it may resist protons a little bit better for those oncologic cases if you're going to use proton radiotherapy, but they have very good results with this. If you're going to do that, I encourage you to visit them and see how they do it, because it is not the way that you will have in your head. They have a very specific way of layering these grafts, and you will see why do they have those great results. I did that a few years ago, and I was really impressed on how meticulous they were and how reinforced was their technique as opposed to what I had in my head that they were doing. So anyway, we continue. So other things that you may think about is really, especially for oncologic cases, we used to hear that intracranial extension was a contraindication to an endoscopic approach. It's not so, but it definitely adds to the level of difficulty for the approach. So you should not tackle this very without thinking about it. But the technique is basically done in the same way. In this particular case, you can see the displacement of the brain from the tumor. It was not invading the brain. Now, when you have intracranial extension that is invading the brain, like this patient, the main question is not going to be really the approach that you're gonna use, although you may want to use an open approach for some of this. The main question is how are we going to alter the outcome of these patients? How are we going to increase the survival on these patients? Because once you have that, it is beyond a surgical cure. So we need something that is not surgery to cure that patient. Again, we have other contraindications for the use of a pure endoscopic approach, although you can always use an endoscopic approach as an adjunct to any of this. So if they, as I mentioned before, lateral extension, if you have antral extension, the patient needs a maxillectomy. If the patient has an orbital invasion, a tumor that is lateral to the optic nerve, tumor that is invading the skin of or the anterior wall of the frontal sinus, it doesn't make sense to try to remove it just with an endoscopic approach. You will need an open approach of some kind. Now, if you have something like this one, is frontal sinus invasion, and it goes very high, this is one that I would at least do some type of open approach, because I can reach this area with an endoscope. But once I remove the back wall of the frontal sinus that high, it's going to be very difficult to reconstruct that area, especially if you have to remove dura. Brain invasion, I told you, is not a contraindication, but there are cases that you have to think twice before doing it endoscopically, especially when you see brain invasion of this nature, which is like a mushroom. What happens here is that as you remove the base of this mushroom type invasion, the brain starts closing in on the sides. So before you can remove this upper part in here, you're going to have brain on your way. So when that happens, it's incredibly difficult to complete the resection of the tumor. Another one, if you have tumor like this one that is extending on the convexity anteriorly, the tumor really has done most of the job for you in the sense of brain retraction. It has moved the brain already up. So it will be much easier to remove this tumor through an open approach that use a pure endoscopic approach. And the morbidity of the open approach is already done, at least the morbidity in regards of the brain. The brain has already been moved. So it will be, it nullifies the advantage of the endoscopic approach. If you have something like this, a poorly differentiated tumor or a SNOC, this is not a matter of whether to use an open or an endoscopic approach. This is just a matter is that it's a non-surgical disease. These ones we cure with chemoradiation. If you have to excise the periorbital, we can do this endoscopically, but it's very difficult to reconstruct the orbit through an endoscopic approach. We don't have a very reliable way of doing that, so you're gonna need some type of open approach to do that. So from my standpoint, we always think about these minimum invasive approaches as avoiding incisions and avoiding osteotomies, but from my standpoint, the main advantage of the endoscopic approach is the lack of retraction of the brain. This is a study that I did when I was a fellow back in the 1990s, and you can see here, this is using an open approach, and the morbidity in regards of the brain. 3/4 of these patients develop encephalomalacia, which means that they have a scar in their frontal lobes. 1/3 of them had contusion, and 1/3 had edema, and infarction of the brain. You can see that is a significant number. This is an international study looking more or less at the same thing, and you can see that the morbidity of the brain retraction is confirmed in this study. They had a mortality of 5%. So minimal brain manipulation is really the main advantage of the endoscopic approach. I'll show you an illustrative case. Here's a 72-year-old man. We used to say that people more older than 65 years of age did not do so well with the open approaches because they all had personality changes that were to some degree permanent, maybe some memory changes. But this guy, you can see him 6 months after the resection, very minimal changes of the brain, and the changes that they are were caused by the tumor, not really by the approach. Olfaction sparing, when you can do it, is important. And by this, I'm going to try to preserve some olfaction. That's not to say that the patient will have normal olfaction after we do it, but in the patients that we have done it, and this is a potpourri of both benign and malignant tumors, we have been able to preserve some olfaction in 80% of them. Now, The problem with olfactory preservation is that it's possible, but it's somewhat unpredictable. I have had patients that have normal olfaction tested by the Sensonics test, a validated test, and I sent him for proton therapy, and after proton, they just don't have any olfaction. They lost it during the radiation therapy. So surgery is not the only factor for the preservation of the olfaction. As you can see here, we have many other factors that can contribute to the preservation or the loss of the olfaction. And again, cosmetic, we talked about it already. I said that is not the main complication, but when we look at the series, 20% of these patients had some type of wound complications. So in regards of surgical planning, I think that the traditional approach, obviously, you will have tumors that are resectable by traditional, that are not resectable by endoscopic. From the standpoint of operability, there are patients that you could tackle endoscopically that would not tolerate a traditional approach. And in regards of curability, they are the same. So reconstructive is, I have to say that it's easier to reconstruct from a traditional approach. And of course, lifestyle, the endoscopic approach has a great advantage. Another thing to consider is that even when you are an experienced surgeon, you will have some patients that you will have to convert. And this is frustrating, and it requires incredible discipline because at the end of the surgery, when you're finished, you send that frozen section and it comes back positive, and you cannot take any more through the endoscopic approach. You're going to have to convert the patient to an open approach. And this is in our original series of 22 patients. You can see here one we converted. And again, I converted one a couple of years ago. So even after so many years of doing this, once in a while you get surprised. So I'm going to give you some editorial comments about this because the endoscopic approach have been compared to the open approaches, and I think is not two things that can be compared unless you do a randomized study on the same institution, because the indications are not completely different. What the conclusion you can have, though, is that the endoscopic approach, when you look at the local regional control, is at least comparable to the open approach, and in some cases may be superior to the open approach, especially for small cases. But comparing ones against the other is really not a fair statement. So here you have Piero Nicolai's series, one of the largest series in publication, and you can see that obviously the endoscopic approach seems to be better. However, he did the cranioendoscopic and not the endoscopic for a reason. He did it because the tumor was beyond the reach of the pure endoscopic approach. So again, they cannot be compared. The other thing I want to mention is that having a team that is dedicated to this is really key to the outcomes. So when we talk about the outcomes of skull-based surgery, it is kind of a misnomer, and it's kind of a little lie, because the truth is that it's not the outcomes of the surgery, it's the outcome of the surgery plus everything around it. So you will need good neuropathologists or pathologists that is experienced on this. You will need great anesthesia. You will need a team of people, and I think this has been the greatest development in a skull-based surgery in all the years. It's not the creation of techniques. It's not the design of new instruments. It's really the teamwork that we have nowadays. So to help us with our approaches, we have to realize that other fields have also advanced. Now proton therapy has become more available. We have better imaging than 30 years ago. This is really important. We have better pathological differentiation because our imaging is very exquisite nowadays. But when we look at the images of these tumors, they all look the same in the images. So basically, they can be confused. You can see patterns that are trend to be certain tumors, like this is SNOC. There's something like this is either a SNOC or a lymphoma, or sometimes a not carcinoma. But even fibrous dysplasia in an MRI can look like a malignancy. So that's helpful to some degree, but it's not going to help you to establish the diagnosis. H&E, many of these tumors have a neuroendocrine differentiation, and many of these tumors fall into the category or a small blue cell tumor. So the H&E is not very helpful. That's why I recommend that you should not do a surgery based on the frozen section, because a lymphoma, a sarcoma, a melanoma, anesthesia can look very similar on an H&E, and they may have very different treatments. So nowadays we rely on these immunohistochemical markers to help us with the diagnosis. So finally, I want to just mention briefly, since they asked me to talk about techniques of the planum sphenoidale. So basically, this technique we use is for either a craniopharyngioma, or in the case of anterior skull base meningiomas, as you can see here. Again, you have to look at whether or not the tumor is involved in the vessels. Here you have one that has no vascular involvement. The vessels is away from the tumor. So this is one that we have no trouble approaching endoscopic. Here we have one with vascular adherence. That means that the vessels are around the tumor. This is one that we're going to be a little bit more careful during the surgery. And then you have some that will have vascular encasement, where the artery is actually going through the tumor. And we may not want to tackle that endoscopic in many cases. So exposure of the planum, I'm not going to dwell too much on the nuances of the technique. We have done a bilateral approach, as you can see here. Why the sphenoidotomies? We're going to expose the sella, and we're going to expose the optic canals. And once you do that, you're going to remove, you're going to do a wide cellotomy. This is going to make more sense in a second. Wide cellotomy, and then you're going to remove the bone in between the optic canals. Once you do that, it is our preference to really thin down the bone, and when it's very thin, then remove it from anterior to posterior. But that's just a personal preference. We have seen people doing this in multiple ways, and they all can work. So I'll skip through some of this for the sake of time. But here you're beginning to see the exposure of the dura. Here you have the sella. Here you have optic on both sides, and you can see the tuberculum sella used to be here. And this is the meningioma, the meninges of the planum sphenoidale. So when you look at this, it has kind of the shape of an SP-tune. You basically have the sella exposed, and then the planum sphenoidale, and it's time to open the dura. We do it in layers, make sure that the optic nerve and the chiasm is going to be away, separate the dura one layer at a time, so you're sure that, again, you're not damaging any structure. Of course, the imaging may give you an idea on whether the chiasm is going to be posterior or anterior. And in this case of this meningioma, we're dissecting it bimanually, just like it would be done with an open approach. This is at the end of the resection, and then the reconstruction is like we mentioned before. In the case of transplanum defects, we tend to use collagen matrix followed by the nasoseptal flap. In this particular case, the nasoseptal flap happened to be a little bit small, so we reinforced the nasoseptal flap with fat, bolstered with some packing, and that was the end of that surgery. So in conclusion, I think that the endoscopic approach gives you better visualization than many of the open approach and the microscopic approach, and it requires no brain retraction. It uses two surgeons, which is both an advantage and a disadvantage, as I'm going to mention before. Having two surgeons, you have somebody focusing on the surgical field, and the other person is really focusing on the panoramic picture. And it becomes a conversation during the surgery and leads to better outcomes. And disadvantages, the main disadvantage is that it's really a steep learning curve. You really need some volume to be able to develop your skills. And more important, a big disadvantage is, again, that it requires two surgeons. And the main disadvantage of this is being able to find somebody that you can work as a team. So once you have that relationship with that person, you have a relationship of trust and of value, you will have a team that will grow together. And by value, I mean that the two together become more than just two surgeons. It multiplies the value of each one by helping each other. And again, another disadvantage is the need for instrumentation, technology, etc., etc. So instead of thinking on these 3 counts of traditional surgery where I can do it bigger, endoscopic surgery that I can do it smaller, or an in-between, I think that you should be able to move from one to the other according to the needs of the patient and to the biology of the tumor. And then remember that this is about the treatment of these tumors, even benign tumors of the skull base, is a combination of this. It's a multidisciplinary treatment. It's not just surgery. It's really a combination of all these things that we have here. And nowadays, I would even put medical oncology on this picture because they have become more and more important as targeted therapy and immunotherapy have come into play. So I'm gonna leave you with an advertisement for our course. We usually have a course every year. We usually have it in October. Obviously, COVID has changed our life, and for the most part, not for good. So our next course is going to be spring here in Columbus, Ohio. So if anyone is interested, we would love to have you visiting and show you our place. Thank you so much.
Thank you so much, Professor Carlo. Thank you so much for your brilliant, I would say dazzling lecture, as we expected from you. And now, thank you for having been so keen to let us at least a quarter of an hour for our discussion. And as I said to you, I would like just to share with you, excuse me, just that we call a cafe-like talk. Could you please just give us some idea of the way you got this exceptional academic background, how you made your choices, and was it random or planned? Your mentors, you made landmarks on your careers.
Yeah, sure. It is interesting. When I started my career, the goals that I had were completely different. So when I finished otolaryngology, head and neck surgery, I owed some time to the U.S. Air Force. So my idea was to pay my time and go back to Puerto Rico, where I trained and where I grew up. But I did a fellowship at the University of Pittsburgh, and during that time, Ivo Janica and Laligam Shaker were the premier skull-based surgeons in the world, and they had this first skull-based center, and they were doing these fantastic things. So it opened my eyes to that world that was beyond the traditional head and neck surgery. So I went back to the Air Force, and when I finished my commitment, the University of Pittsburgh, under the auspices of Gene Myers at the time, he was the chair, they offered me a job. And I felt like a kid in the candy store. So I couldn't pass the opportunity. So I joined the University of Pittsburgh. So all these things that I have done and all these things that have happened in my academic life were somewhat of a combination of random events, a lot of luck, great mentors, and just having an open eye to new opportunities. And just trying, the one thing that I had that helped with that is that I wanted to contribute. I wanted to contribute to the team. So when I joined the University of Pittsburgh, I was the bottom of the totem pole, so to speak. I had great mentors and surgeons above me. So I could not compete with them in the sense of reputation, in the sense of referrals, in the sense of know-how. So I tried to make my own niche. So my own niche was help with the skull-based center, create the swallowing center, create later on a silent endoscopy center in conjunction with Barry Shitkin, at the University of Pittsburgh. And I tried to fill the gaps that the group had. And by doing that, I created my own practice, which is, I guess, I never thought about it, but as I have grown older and people come from different places and look at what I do, it is somewhat unique in the sense that I still do multiple things that are not just the traditional head and neck surgery, even when I'm supposed to be completely subspecialized. And I have tried to combine the things that I learned. There's maybe a trend within the specialty to try to break up the specialty, break up maybe into somewhat of a general ENT, somewhat of a head and neck surgeon, maybe otology. And you can see the different groups trying to fragment the specialty. And from my standpoint, that would be a huge mistake, because what we learned when we are in a true general otolaryngology residency is we learn from all these things. I still do things that I learned from the otologists, and I do things that I learned from things that I don't really do anymore, cosmetics. So you really become better by that exposure. And again, and not to mention that we would become 5 different specialties of very little power to fight other specialties when we try to fight for more space or whatever we need to fight for. So going back to your question, I did not have a plan. I just keep walking and took the route. And if it happened to be not the best route, I didn't go back. I just continued walking and tried to make the best out of it and find another path and take that one.
I think it's the most difficult thing in life to choose the way we are. Perhaps there is a projection for us. How do you feel that? Is it just random?
Yeah, it's not. Again, it's not entirely random, because you pick as you have different options, and you pick the ones that are of more interest to you. The way that they present themselves may be random, but they are multiple, and then you choose. And when you choose, you should do it with full commitment. You should you should not choose something that you don't feel passionate about. Otherwise, you're going to do it halfway, and that never has the best outcome possible. So everything that I chose.
I just stop you a second. I'm going to translate a little bit. Donc, le professeur Caro a un parcours exceptionnel et je lui ai demandé si c'était l'effet du hasard ou d'un choix vraiment précis. Et en fait, il me dit, bon, il a fait son parcours comme nous tous en fonction des opportunités qui se présentaient, et ce n'est pas un choix réfléchi, c'est la vie qui a choisi en fonction des éventualités. So another question, Professor Caro. Are you from a family of doctors? In your family, are they doctors?
There are a couple. When I was growing up, I had a cousin that was a gynecologist. He was not close by. He was many years ahead of me, so I couldn't use it as a role model, but he was there. Somebody else in the family had done it before, and he was a brilliant guy. He had a very successful career. And then after me, there have been a couple more that have done it, including my daughter. So my oldest daughter is finishing her plastic surgery residency in a year. But I did not come from a family of doctors. My mother was a teacher. My father had a little country store. My oldest brother is an accountant. The next one he was a radio and TV technician. Then the next one is an engineer. So we all did different things.
You know, this discussion is, we know your work. I would like to know you more. What is behind this work, the work, the man? So you partially answer to us. The second question I would like to tell you is for a new bill. for someone who is new and very attracted by this field, neurosurgery, ENT, and he wants to go to your footsteps. What is the best? How to reach this degree of knowledge?
Well, I hope that they reach higher than that. I think that, again, commitment, passion for what you have. I think that if you have those two things, and you don't have to have super skills, you can have normal skills, but if you're committed to improve yourself, you will continue to follow that curve and become better and better until you are at the top of the game. Of course, nowadays my path is different for many people. So as I mentioned, I follow this semi-random pathway. Not everybody works that way. And many people works with a very specific plan. So find your pathway, try to find a mentor. A mentor doesn't have to be close by. It can be by afar that gives you some advice. So you take the most efficient pathway. Try to train in places that gives you the experience. And if you don't have that capability, do it after you finish your training. You can do a fellowship, or you can do visiting scholarships by visiting different people around the world, and continue to do that. I still learn many things every time I see somebody operating.
I can't say it for the audience. Donc, Monsieur Caro, lui, ne pense pas au génie. Il pense que tout le monde peut arriver à avoir un degré de connaissance pourvu qu'il soit passionné et qu'il puisse se mettre au travail petit à petit, et la connaissance ne s'arrête jamais. And the last question is your vision of the future, not only in science and ENT, and how is your view about the future? Quelle est votre vision du futur professionnellement, en sciences, en otorino, et aussi là où va le monde? Thank you.
So, well, we have a bright future ahead, COVID aside and everything that is happening around the world. If we look at the advancements in technology, we're advancing at such an exponential rate that society is going to change in the next 20 years. It's going to change, hopefully for the better. There are some challenges and some dangers, some risks, but I think that it's going to change for the better. The resurgence of AI is changing our life. We think that AI is going to come. AI is already here. Every time you open your computer, you have machine learning already picking for you different choices. My toaster probably have an IQ that is similar to mine now. It's already here, so it's going to change our life. I think that sustainable energy is also going to change.
Aren't you scared by that? Aren't you?
Yeah, to some degree. To some degree, I think that that's some of the dangers that can happen. I think that if you invent something that is smarter than you, sooner or later, that device is going to realize that it's smarter than you and doesn't need you anymore. However, if you use it in a way that enhances your capabilities, like you have a hybrid of human and computer, that's going to be a fantastic thing. It's going to help us to advance.
At what time you must leave?
Don't worry, I already talked about a commitment, but
it's so interesting.
I will be late.
I just translate for the audience. Donc, Monsieur Caro, lui, pense que le monde changera, comme je l'ai dit. Il y aura de bonnes choses, il y aura aussi des choses mauvaises, mais dès à présent, il y a l'intelligence artificielle qui permet des résultats bien supérieurs à l'homme dans certains domaines. Alors, je lui ai posé la question, est-ce qu'il n'avait pas peur de cette situation? Il me dit, bien sûr que j'ai peur, mais car certaines inventions peuvent aller à l'encontre de l'humanité. Et un jour, quelqu'un qui puisse inventer quelque chose qui soit supérieur à l'homme et le détruire, c'est ça. Donc, je vais ouvrir la discussion pour les gens qui veulent poser et passer la main au professeur Mohamed Zala. We are going to start the Q&A and Professor Zala.
Professeur Ferry,
Okay,
vous m'entendez?
Oui.
Vous avez, il y a quelques questions destinées au professeur Caro. Est-ce que vous voyez l'onglet questions sur la barre?
Oui. Bon, je vois vos questions.
Voilà.
Et je viens de vous envoyer 2 questions. J'ai des questions à poser. Alors, j'ai une question. Attendez.
Si c'est trop petit, vous pouvez détacher l'onglet questions avec l'icône, une petite icône, un carré avec une flèche à droite.
OK.
Voilà.
Très bien.
Voilà, c'est parfait.
Alors, j'avais vu une question de... Bon, pour le moment, je ne vois rien d'autre. Je ne sais pas si ça a été envoyé ailleurs. Donc, je vais rendre la main au professeur Zallar, s'il veut bien. Lui, il avait des questions à poser. Professeur Zallar, vous m'entendez? Thank you so much. I'll end by some words after. Donc, est-ce que vous êtes là, professeur Zallar? Mettez votre micro, s'il vous plaît.
Maintenant?
Oui, allez-y.
You hear me now?
Yes, we hear you.
So, first of all, thank you, Professor Caro, for this excellent, clear, and informative lecture. I myself have a question for you. So, in terms of anterior skull-based mesenchymal resection by endonasal endoscopic approach, what is your strategy to be more preventive in order to avoid internal carotid artery? What's your own policy to deal with this complication when it arrives? In the same regard, what about using a balloon test occlusion stent? Another question is about harvesting a piecemeal of bone tissue or soft tissue in per-operative histopathological exam in order to ensure the margin of the lesion. You understand my question, I think?
Yes. So
it was heard?
in regards of the carotid, it is rare for the carotid to be involved with an anterior skull-based lesion. It can extend posteriorly and maybe get the carotid, but it depends on the pathology. Like for example, I would do things in a meningioma that is different from what I would do in a malignant tumor. I think that if you have a malignant tumor that is around the carotid, again, it's probably not a surgical disease anymore, and we go to other things. But if you would have to if it is something that you're considering sacrificing the carotid, then I would do a balloon occlusion test. But if in general we don't do a balloon occlusion test just in case, so to speak, we do it if we think we're going to need it. And the reason for that is that the balloon occlusion test itself has some morbidity and is not completely accurate. So it doesn't really protect you completely, and it may cause some complications. So we're very selective on who do we use it. During surgery, I would use, of course, a navigation, and I would use a Doppler. And if you have one available, you can use an ultrasound. All those things will help you. And we have different landmarks to try to identify the carotid and to identify and to protect it. The second part of your question, sorry, what was the second part?
Second part was about your own policy to deal with this complication when it arrives. And in the same regard, what's
with the
about using balloon test or stance test, or balloon?
Yes. So if you are sacrificing if you injure the carotid, usually we use muscle to stop it, and that patient is transferred to the interventional suite or to the endoneurosurgical suite. In my hospital, the angiographers are neurosurgeons. They are both exo and endovascular neurosurgeons, so it's very easy to communicate with them and to express the goals of what we want to do. If it is in an area that they can stent or put what the so-called pipeline, that's what they do. So you preserve the flow of the carotid. If it is in an area that they cannot do that, then and they have to sacrifice the carotid, then they do a balloon occlusion test. If the patient passes the balloon occlusion test, then they may sacrifice the carotid, and by that I mean they plug it. They put something inside the carotid to thrombose it. If the patient doesn't pass, then the option will be to bypass the carotid. And that's what they do. They basically bypass from external carotid to middle cerebral or something of the sort. And that has its own array of issues, but that's more or less the protocol that they follow.
I have a question of Professor Benariba. What is the limit of CT scan of intracranial extension if you decide not to use endoscopic approach?
Well, CT scan is very good for the bony changes, so it doesn't tell you a whole lot about the soft tissue changes. There are some tumors that you can identify on a CT scan, but if you are using it to guide your approach or to guide your resection, CT scan is not perfect. There are some things, of course, is better than nothing, but it's really gonna misguide you. It depends on the tumor that you're dealing with. Now I remember the other part of your of the question, Dr. Salak, was in regards of the margins. So I don't think that taking the tumor in block or taking it in piecemeal matters that much. I think that has been proven in other parts of the head and neck. The important thing is to remove it completely. So yes, we do encourage to use the frozen section analysis throughout the surgery. We jokingly say that we keep the pathologist employed in my institution, because usually in a skull-based case, we may send 30 different samples of different areas that we have concern. So we do guide our resection with the frozen section.
I have another question of Professor Martin. He's the head of Department of ENT in Casablanca, and he asked, what about just an advice on how to manage hemorrhage during the operation?
It depends on what type of, I think that it will depend on what type of hemorrhage. So there are basic things that we do at the beginning of the surgery. We use adrenaline, 1 to 10,000 in platelets that we put in the nose. Then we elevate the head of the patient about 20 to 30 degrees. That is fantastic to control capillary type bleeding. We use hemostatic pastes in places like venous sinuses and small arteries going through the bone, et cetera, et cetera. When you're talking about catastrophic hemorrhage coming from a carotid, I followed what I mentioned before, is that we maintain the visualization. So we have the two surgeons working at the same time. We usually, in any case that we're gonna get close to the carotid, we have the thigh prepped. So in case of an emergency, that thigh is a source of muscle. We get the piece of muscle as soon as we can. We crush it. For whatever reason, crushing the muscle releases some magical factors that helps to stop the bleeding. And then under visualization, we press that muscle over the vessel until it stops. It usually takes about 20 to 30 minutes. If it doesn't stop, then you have to do something else. Yes.
Another question in the same field. There are a lot of persons, they are interested by the issues. And Professor Raji who is the head of the Department of ENT in Marrakesh. He wants how to avoid these issues. What are these issues and how to avoid them?
Well, again, I would need some more specific. What particular issue are we talking about? Because if it is a mucosal hemorrhage, as I mentioned before, is having vasoconstriction, having the head elevated. Oh, we also irrigate throughout the case with warm water. So we don't know exactly why it works, whether it's by swelling the vessels and plugging them or triggering the coagulation cascade, but warm water seems to work.
I turn with the question, what are the main issues and how to stratify them from low level to the maximum level?
Well, again, the low level is capillary bleeding that we all see in the nose, whether you're doing a skull-based surgery or you're doing some type of nation. Those are things that we talk about all the time. The two main issues in the skull base are the venous sinuses and the carotid. Or if you go intracranial, then you have the circle of Willis. And the circle of Willis is controlled more or less in the same fashion of the carotid. The difference is that when you have a carotid bleed, for the ENT side, most of the time that carotid is within its canal. And if it is within its canal and you are extradural, you can pack the nose and save the day. So if you're by yourself in a hurry, you can pack the nose and stop the bleeding, take the patient somewhere to treat it. But if you have opened the dura or that carotid is outside the canal, it's going to be much more difficult to do that. If you put packing, if you stop the bleeding, you're going to stop the flow on the carotid, and the patient can stroke. If the dura is open, what you're going to do is divert the flow of blood into the head, and that's going to be a terrible outcome. So those are two situations where we do our best to avoid, but we have never had a carotid bleed with the dura open. We have had branches of the carotid. We have had bleeding from the circle of Willis, and you either stop it with muscle, stop it with coagulation, or stop it with an aneurysm clip. So it depends on the case. We may have any of these specialized instruments available because we know that they are a possibility.
Perhaps our chair would like to. Tu veux poser des questions, Leïla? T'entends pas. Le micro.
Je n'ai pas la liste des questions, c'est toi qui l'as fait, ça. Je n'ai pas reçu la liste.
Très bien. Est-ce que vous voulez que je poursuive encore parce qu'il y a d'autres questions qui arrivent?
Oui.
I have another question from Mr. Tubali from Tanzania. Hello, everyone. I'm very interested and it was very interesting and clear presentation. My question for Professor Carol comes to you. How do you proceed to learning for your students for training? I know that the legislation is very difficult to practice and operate a first patient for a surgeon. How do you go for a theoretical course and on a dummy to real patient in surgery?
Yeah, so I'm assuming that you have developed your basic techniques in residency. If you haven't done that, then we have to go back to the basics. But assuming that you have your basic techniques of rhinology and oncology, and you're beginning to get into the skull base, you went to a course, and you feel okay about your technical ability, I think that that's the time that trying to hook up with a mentor is important. Because there are many questions that are going to come in your head, and many techniques that can be applied to a particular problem that may not come to your mind during the case. So if possible, and I know that this is not possible all over the world, and it's not possible to some of us, is is try to get a mentor that can help you with the different questions that they're going to have, from analyzing the surgery, analyzing the pathology. I can go with you through all different problems that you may encounter, and will help you even during the surgery. You can also try to go and watch experts and see how they do it, and see how they handle the different situations. Like all these questions are really important questions, but it's hard to really transfer what we do from the surgery into words, right? You have to see it. Many of these techniques is very hard to tell you about all the details of how we position the patient, what things do we do in the operating room to make sure that things go well. And this is what I was emphasizing before. It's really teamwork. If one of the steps gets changed, it may change the entire change of events. So when I show you the lecture, I show you it's a very condensed version of things that went well. But there's a lot of things that behind the scenes that adds context to all this. And we have many visiting scholars, many people from all over the world that they come for that. They don't care about the technique anymore. They can do it. They're doing it at home, but they have gone in the learning curve and they have plateaued. They cannot get the next step. And that next step is usually simple things, little details that we do before the surgery, during the surgery, and after the surgery that really makes you go up in the scale.
You open the doors.
Yes, and that's what I meant before when I still go around and see surgeons, especially good surgeons, operating. I learn a lot because everybody has developed their system, and I cannot take their system and put it into mine, but I can adapt and put little steps of their system.
Just make them in confidence.
Yes.
When they are working together, they take confidence. I would like a personal question. What do you think about robots and intelligence, artificial intelligence?
Yeah.
We have said some words about take it, but just robots.
Yeah, robots in general, they have always, they're fascinating, right? Because they will. That's one of the things that can make you a better surgeon. You have the Da Vinci robot that, as a head and neck surgeon, is something like the name of the company. You can sit down on a robot and it's intuitive. You're not changing the way that you're doing surgery. You're just enhancing your surgery. The problem in a skull base is twofold. I mean, there are many more problems, but one, suctioning in the skull base. You need, if I'm going to have somebody suctioning in the patient, that really defeats the purpose of the robot. We should have a way of suctioning with the robot. The other one is a drill, a high-speed drill. For the skull base, they say the saying of anatomy is destiny. In the skull base, anatomy is density. It's all bone. So if we don't have a good drill, we cannot advance in the skull base. The other issue is size. All the robots nowadays are very big. However, there is a line of robots coming up that have been scaled down in the size. They look very similar to the Da Vinci, but they're very small. There are drills that are being developed that can even curve around structures. They're flexible instruments that they become rigid when they get to certain points. And all these are somewhat machine. They have included some of a little bit of a machine learning. There are robots already in the orthopedic field, especially, that you tell them where to drill, and they go and drill.
I think there is a misunderstanding about Da Vinci. It's not really a robot. It's a micro manipulator. There is no intelligence inside. I am wrong? That's only a tool for more precise gesture. Is that
yeah,
right?
by the broad definition, it is a robot, but you're right. It's not an independent robot. It's not doing the work by itself. It's a micro manipulator that the surgeon is using to enhance.
Not autonomous. It's not at all autonomous.
Yeah, so that is the case. But if you look at the different categories of robots, yeah, that's one of the categories. But that's absolutely the case. Now, if we're talking about when are we going to have a robot that is completely independent, that is going to eliminate the surgeon from the field, that's going to be a lot of years. Yeah, I don't think I'm going to.
Another last question. What is the best material to close the fistula of the skull base?
The best material is vascularized tissue. So if you have vascularized tissue, again, vascularized tissue, you cannot have better healing than that. But that does not to say that there are other materials that you cannot use. I continue to evolve with this. I started using fascia lata. I then went to a cellular matrix and to collagen matrix, and now I'm back to fascia lata. We're still always looking for what is best. I can tell you in concept, the best is a multi-layer technique, so not just one layer, and something vascularized. That's in general, that's the best. If you don't have that, then I think fascia lata is probably the best we can have. And we were trying to avoid it because, of course, it has its own issues and own morbidity. But in all truth, fascia lata and fat are really good for reconstruction.
Fat and fistula. Okay. I just want to, before giving the floor to our chair, I would like to thank you so much, Professor Caro. That was exactly what I expected. We are proud to have shared with you these moments, and we will miss you. I hope that's only the first footstep of our relation. Como dicen los españoles, solo una ración de etapa of our collaboration. God bless you. And I leave the floor to Professor Sakali.
Thank you. To all my fellow doctors and friends, you have been many to attend this webinar, and it is heartwarming. We are pleased that our colleagues from Algeria, Tunisia, Mali, Burkina Faso, and many others have been able to join us. This is an evidence, if necessary, of our shared passion for knowledge. A special thank you to our guest, Professor Ricardo Caro, that has praised us with his scientific sharing, and we hope to see him soon in Morocco. I also want to thank the moderators, Professor Faisal Al-Fihi and Professor Mohamed Zalar, for moderating this session so well. Finally, we thank the Botu Laboratory for their support during the pandemic by allowing us to use this platform to organize our webinars. The recording of this webinar will be broadcast in the upcoming days on the website www.smorl.mr. Thank you to everyone. Have a nice weekend.
Thank you for having me.
God bless you.
Thank you.
Merci Leïla, à très bientôt.
Merci beaucoup. Merci.
Merci Si Mohamed, à très bientôt au Maroc, j'espère.
Merci. Oui, j'espère, Inch'Allah.